older units. Some of these have like a display panel which basically connects to the robotic system, but this one doesn't.
Okay.
So 2 jacks for the foot switches.
Okay.
Monopolar, bipolar, power switch. There's a smoke direct link down there that can connect to a smoke evacuator.
Mm-hmm.
There is a big lag with that though, because it tries to read the energy to the smoke evacuator, and a lot of times it's not very quick. So some people say that they don't like that, just full transparency. This is the bipolar and then the monopolar and bipolar adjustment. So there's 2 little things on the screen. I'm blocking everybody. It will just basically adjust the desiccation noise that occurs with the bipolar, and then also basically anytime they're doing monopolar and bipolar, there's little noises with that. You can adjust that noise too if it's too loud. So these 2 little switches down there will adjust all those noises if they're bothering you. You can turn it down as much as you want. I've been in a lot of hospitals and I know the noises bother people. So we have grounding pad here. So you guys do know how to turn it on, obviously. Is it plugged in?
It should be. Yeah, it went off when you were pointing at the stuff at the back, so they might have
Wiggle
got
the plug or
loose.
something.
Do a little troubleshooting.
There you go.
There you go.
So if the plug is loose, it will not turn on. We have the grounding pad. Depending on if you're using single foil or double foil, so basically, like I said, you guys know the difference between like the double foil and the single foil, just better contact, better reading between the 2 portions of the pad versus like a single foil pad, which has just like a 1 read. So most people use the double foil nowadays. The double foil has a little meter here that you can see the connectivity. So that's nice for a lot of nurses. Do you guys use the single or double now?
Double.
We don't have any singles at all.
That's a good answer.
I don't know what this one is.
It's double, I think.
Is it double?
Yeah.
Okay.
Yeah.
It won't read until it's on a patient, so we can't see. Yeah, it does look double. But basically, last time I did that, I shocked myself in front of the whole team, and I was like, "Oh, never again." So I tried to cut a piece of chicken in front of a hospital, and it zapped myself a little bit. So double foil basically allows you to see how much it's falling off the patient. So that's nice for you guys, because as it kind of slowly works down, it will be green all the way down to red. Red meaning that it's no longer connected or no longer viable. It's not going to let the surgeon cut or coag at that point. But you can look for that full green bar to show you that you have indeed gotten a good kind of patient contact with that grounding pad. As it's starting to wear down, usually the grounding pad is slipping off the patient, or there's like some condensation, moisture building up on the patient and starting to kind of decrease that connectivity. How in depth do you want me to get on programming and stuff? Do you guys ever program it for surgeon preferences? Is that something that you would like to be able to do?
We do it.
You do it?
Yeah.
Okay. So yeah, you can program whatever settings you want into the system. L will pop up here, meaning last. So it will always default to the last setting, and then you can adjust it based off of the number that it reads on that screen to whatever surgeon you want. So if you say, okay, general surgery likes 1, urologic surgery likes 2, GYN likes 3, you can kind of adjust the cut coag settings and the bipolar to fit that, so that way you don't have to kind of play around with it. You can just pop that number in there and it will automatically default back to that specialty setting. You also want me to go into the modes and stuff? So these are usually surgeon preference, but we have general, we have fluid, and we have lap. So general is going to be the default, so you can use that for all stuff. Fluid meaning like arthroscopic procedures or hysteroscopic procedures where there's like a greater chance of fluid in the system. It basically will allow that kind of energy to be dispersed to the joint or to the kind of uterus, basically, if they're trying to do like hysterectomy or if they're doing some other kind of GYN procedure. Urology likes lap sometimes, or the fluid mode sometimes too. Typically, most people use general though, or lap. Lap is nice because basically it prevents like capacitive coupling. So if they're using multiple sources of energy, or if there's kind of metal trocars in there, or whatever you're using it for, if you're using like an extended L hook or something in the cavity, it's nice to be in lap mode because basically it will prevent some of that transference of energy. Like an indirect burn can happen to the patient if you're in a different mode. So some surgeons do like that lap mode for that reason. Not sure what you guys typically use here, but it's a good option. Cut, coag, bipolar. You can adjust these in multiple ways. So right now we have it on blend 1. We have all these little buttons next to the respective kind of decisions you have. So you can do general, fluid, lap, and just press that little button. This is how you adjust. So you guys have 2 settings in there right now. We have 1 setting in there actually, sorry. So we can program it to multiple surgeon settings if you guys have some in mind. I'm happy to do that for you guys, but it's defaulting to last, and then you have a setting of 1. So this is how you program it. And to do this, you basically press that button, adjust the settings to whatever you want it to be. And then you basically hold it until it beeps at you, and then it'll register that as 2, and then basically you have another setting built into the system. And so, but like I said, it will always default to L for last, and then you'll have to just manually kind of adjust it to whatever you guys want. Pure blend 1, blend 2, and blend 3. We all understand kind of difference on that one, or do you want me to jump into that a little bit? Pure is basically like a scalpel-like function. It's going to be a very precise cut because basically it's all cut energy. As you go down the blend modes, the cut decreases and it turns into more of a coag function. So blend 1 basically knocks down the cut about 25%. Blend 2 knocks it down to about 50%, so you're about half cut, half coag. I'm sorry, I'm completely neglecting everybody back here. And then blend 3, basically the cut is about 25% and the coag increases about 75%. So depending on how much hemostasis you want, it's nice to kind of have those options. If you're having a heavy bleeder, you can increase that blend function. The surgeons usually like that. The other thing you can do with the cut, the coag, and not the bipolar exactly, I'll get into that in a second, but the cut and the coag is you can add a pulse function in there. Do any of your surgeons use a pulse mode? The pulse basically accentuates the mode that you're in. So if you were to put pure cut and then also add the pulse in there, it's good for like gastroenterologic procedures where you basically get a little bit of a pulsing of energy and allows them to kind of cut and then kind of get a little bit more visibility so they don't actually cut too much. So that's why they like it for really fine dissection type situations. You can do the pulsing with the blends as well. As far as coag goes, and so that pulse button is over here. This is just the pulse one. You press it to turn it on, press it to turn it off. Coag, we have spray, standard, and then we have pinpoint. Not sure what everyone uses here. Spray is basically like a very it's the most coag function on there. So it's like if you just want rapid hemostasis, so you're basically spraying down a heavy bleeder, but you don't want to get too much tissue dissection. So it allows for just kind of a lot of blood control. Standard is kind of the most popular one, I'll be honest on that one. The standard mode basically allows them to have a function that is similar to cutting with that coag. So it's not necessarily cutting, but it allows for a little bit of dissection with the coag mode. Pinpoint is, they use it for kind of fine dissection with the coag of tight spaces. So you're kind of going into a cavity where you don't want to, or going into a tissue bed where you don't want to do a lot of dissection, but you want it to be, or you want more of a depth of dissection, but you don't want as much of a breadth of dissection. So that pinpoint allows them to kind of use that coag function in a more kind of direct manner to kind of get a little more tissue dissection without kind of spraying as big of an area. Once again, just adjusting it by pressing this button. And then you guys know these little up and down areas just increase or decrease the setting that you want to be on. Bipolar, we have micro and macro. Micro being basically a finer version of the dissection or finer version of tissue energy versus macro being kind of for those bigger bleeders, situations like that. So micro, you're gonna see it on some plastic stuff where you don't really have as much bleeding. Macro being more of like the ones where you're trying to control bleeding with that bipolar function. Once again, you can change these. You can't pulse the bipolar through that. If you attach the foot switch in a certain way, you can kind of pulse it, but that's kind of, I wouldn't go into that unless a surgeon's asking about that. But yes, you can't do the pulse with the pinpoint, but you can do it with the spray and the standard. So once again, just pressing that little button there, turning on the pulse. If you don't want the pulse on, just turn it off. So that's as far as kind of going top down for you guys. Okay, now we have down here. So we got the grounding pad connector. We talked about how that kind of is single foil and then double foil. The double foil allows for you basically to see the amount of connectivity. Plug that right in there. This is for the foot switch, or the foot controlled version of the Bovie, basically. So you kind of put that in there, depending on if it's a 5 or 12. The 12 basically to push that in, insert it, and then basically push it in and take it out. If it's the 5mm one, you can basically just pop it in there and it will kind of stick automatically. So depending on the size, you have to use that button. I'm not sure which version of the foot control ones you guys use here. Hand controlled, 2 pieces, so completely the same. If you have 2 surgeons operating at the same time on the same patient with this, basically it does kind of change the settings of the energy. So if both are both are doing cut or coag or bipolar at the same time, it will decrease the amount of energy that's transferred because it's basically pulling at a 50-50 rate. So that's something good to know for your surgeons if they're trying to both cut coag or bipolar and they're using 2 hand pieces at the same time. They will probably notice that they're not getting as much energy transference. Okay, those are the 2 hand controlled ones. Bipolar connection here. You can use either the one that connects, I'm not sure which bipolar you guys have, but like the one with the prongs, or you can use the bifurcated prong set as well, where it's just kind of like 2 little cords and those plug right into there. Okay. What else we got? You don't have to worry about this one as much. What was I gonna say? Output level. This is how you decide how much desiccation level you want with the bipolar. So it will kind of show you how much tissue basically is being desiccated with the bipolar setting. So you can kind of measure that, and that's that one knob on the back of it that churns down the sound on that. As you get to a certain level of desiccation with the bipolar, you'll hear a different audible tone. So we'll go from one tone to a next tone. That kind of means you've reached that level of desiccation that's set into the bipolar output. And that's where you can kind of change that setting on the back depending on what you want. Last thing on here is this is a remote controlled one. So you can use that Bovie pencil, the hand control, or the bipolar. Do any of your surgeons ever do that? They can adjust the energy settings from the field. So you take that Bovie pencil and either do the cut or the coag version. You basically hold it down for 2 seconds. If you want the cut to change, they can hold down the cut for 2 seconds. They can press up or down on the button, and then like cut coag, the top button, I think it's the cut one. You basically press it, it increases it. If they let go of it for 3 seconds, it will basically turn off and it will go back to cutting normally. Or they can double tap it again, and that will basically turn off the adjustment period, and then they can go back to cutting and coag. So that allows the surgeon to do some stuff from the field if they like that. Does not kind of come into play with bipolar, obviously, but for cut coag it does. That's pretty much that. Let me answer some questions if you guys have before we kind of go into too much more. Any questions? And I can kind of review it with you guys too if you guys want to see anything. This is just like an energy, or it's an error warning. When you turn on the machine, it's going to auto-calibrate. So as it auto-calibrates, you will see an error read. If it error reads, give me a call. Or you can turn it off and turn it back on and see if it goes away. It usually does, but if it doesn't, then the unit needs to be checked out because, like I said, it will not allow them to do the energy transference. And then I can kind of review what's on the back of this with you guys as well. You guys don't have, like I said, the one with the little screen on there. This little metal knob on there just allows them to test the unit for energy impedance and all that stuff with the cord and everything. So that's pretty much that. And then you have the foot switch here. Try not to cross the red line. And then, like I said, that just connects to these 2 little jacks on the back, depending on which one you want to use for the foot switch connector. Let's scare you guys with some smoke, and then I'll kind of run through the ones that are gonna be on the questions. It will have little slides for you as well. It's a little easy it's a little easy quiz, so we can kind of run through that. But I'll kind of give you guys the answers, and then you can go and answer them. Let's see. You failed the test after I give you the answers. That's your own fault. So.
I will try my best.
All right. Any questions on the ESU before we kind of jump in? Did you want anything else on the ESU before we jump into the smoke? Okay. And if any of the surgeons have questions, if any of them want to try out the remote, I'm happy to kind of talk that. That's the biggest one that a lot of people don't know, is that they can adjust it remotely from the field too. So that's a nice one. The right one. What are you guys currently using for smoke evacuation? Are you guys using handheld pieces, open tubing for most things? Right. Pencils at all?
Yes.
Some of the smoke pencils? And do you guys know how that connects into the machine, and then if you have the smoke evacuator, how it connects in there? That's where that plug will come into play on the back. There's also a lot of ones that will connect into the smoke evacuator and then into the, if it connects from the smoke evacuator into the ESU, then you can kind of use that Bovie pencil a little differently. With some of them, if it's direct or if it has like a little link on there, you can decide how much lag you want. So like cautery, 2 seconds extra of smoke evac, and then it kind of kicks off, or you can do more and more and more depending on which smoke evacuation unit you have. All right, so most tissue, when it's ablated, about 1 gram is about equal to about 4 to 5 cigarettes a day, they say. Most OR staff is kind of exposed to about 30 cigarettes on an average daily basis. From, if you're in 8 hours of procedures, if you're in 10, it obviously increases more. They say that the smoke basically has 3 different levels of contaminant: chemical, physical, and then also like a gaseous one that basically allows it to filtrate into the lungs a lot faster. So the smoke evacuation is becoming very popular in a lot of states. There's about 20 states in the U.S. right now, and then there's another 10 that have pending legislation. Tennessee is not one of them. They proposed it in 2019 and it got shot down pretty quickly. But there are a lot of hospitals that are advocating for it because of the dangers associated with it. Let's see. All right. So OR nurses and staff and like CSTs and everybody report 2 times the incidence of respiratory illness compared to the general population. That's usually one of the questions in the little quizzes. When a nurse or tech has 15 or more years of experience or of working in the OR, there's a 69% increase rate of COPD formation. So 69% increase incidence of COPD for people who've been in the OR for 15 years or more. We talked about those biological, the 3 ones that will be on that quiz. Physical, chemical, and biological is the term they use. Physical being like that ultra-fine particulate matter that gets into the actual lung tissue. Chemical being the toxins that are similar to cigarette smoke. So there's about 40 chemicals that are in OR smoke from ablated tissue that are present in cigarettes as well. And then the biologic materials, basically visible bacteria and viruses. So that's a big one too. It kind of got popularized with COVID, the COVID period, but also they found that HIV, HPV, HBV, and some of the other, and like COVID-19 all kind of get through its standard surgical mask. So unless you guys are all wearing N95s, the other aspect to it too is that what happens is the surgical smoke gets attached to the moisture from the patient, and so it passes through the mask even easier. So basically it forms like a globule, and it kind of passes through the mask because it attaches to the water vapors that occur from the body cavity, even if it's open or not. This is another question. So particulates of 5 micrometers, which is kind of like termed lung damaging dust, and then particulate matter of 2 micrometers or less deposited into the bronchioles and the alveoli of the lung tissue. Particulate matter of 0.25 microns can cross that blood-brain barrier and get into the lymphatic system as well. These can also pass through the placental barrier, so a lot of labor and delivery places love smoke evacuation because not only is the first thing that the baby's smelling is not the mother's cauterized tissue, but also it can damage, like I said, the baby's lungs as well from that kind of newborn standpoint. The amount of hazardous material in different kind of forms of tissue varies. So obviously skin, fat, lung tissue differs from kidney and skeletal muscle, which differs from liver tissue, liver being basically the most particulate matter and the most hazardous, and then kind of going down to kidney, and then, that's a little bug. It must smell the Chick-fil-A on me. I'll survive, it's fine.
We don't worry about you. We don't worry about here.
I thought you guys were worried about me. Okay, fair enough. So a lot of symptoms that OR nurses do experience, you get it? Dizziness, headaches, eye, throat irritation, nausea, sneezing, weakness, asthma, and chronic bronchitis. Nice job.
I'll lose it.
No, it's over here now.
It's up there.
So another question on there will be: surgical plume contains over 150 chemicals. We said 40 of those are common in cigarette smoke, but then the other 150 are also can be hazardous to humans. Some of the common ones are benzene, hydrogen cyanide, toluene, formaldehyde, butadiene, ethylbenzene, carbon monoxide, and xylene. So a lot of ones that are present not only in like cigarette smoke, but also like gas, or like gas you put in your car has a lot of these same kind of chemicals in it. So you wouldn't want to inhale all this stuff on a daily basis if you don't have to. So that's why it's becoming so popularized around the country, because it is a real hazard, and most states are recognizing it. Some are trying to avoid it until it's like a national mandate, just because of the increased costs. But yes, Tennessee might take a little while. We'll see. But like even the surrounding area, we have Louisiana, we have Georgia, we have Kentucky. Both of the Carolinas just passed legislation. Virginia just put into motion. So we have a lot of surrounding states that have all kind of recognized it. Florida's supposed to pass legislation in the next year. Surgical plume is composed of 95% water vapor. That's going to be a question for you guys to answer on there. That water vapor is, like I said, why it passes so well through the surgical mask into your lungs. Intact cancerous cells have been found in surgical plume. Viable HPV, HIV, and HPV. Viable strands of human DNA have been recovered from surgical plume. Viable bacteria, and then the transfer of disease is possible and has been documented in a lot of studies. And then there's like some slides and stuff that will show up looking at like HPV, chondroloma cases, anything like that. A lot of surgeons that have had no other risk factors have developed tonsillar and nasal cavity lesions and kind of warts and things like that from that surgical smoke, having no other risk factors, obviously. So a lot of surgeons mandate it once they kind of have a thing like that happen, but until they do, sometimes they're a little hesitant on it. Let's see. Surgical masks basically only filter things that are 5 micrometers or above. So most of these things are all below that 5 micrometer level. So that's why having a smoke evacuator with a HEPA or an ULPA filter is really imperative. ULPA being the highest level, HEPA being the one right below it. Basically, ULPA takes out 99.98% of things, and the HEPA is like down to like the 95% particulate matter evacuation. That's going to be one that they kind of talk about in the quiz too. There will be slides though, so like I said, you'll have all the chances to know what you're about to answer before you answer it. 73% of OR nurses report at least one symptom related to exposure to surgical smoke, such as inflammatory respiratory changes, headache, nausea, vomiting, hypoxia, dizziness. Smoke evacuators can filter out to 88 to 90% of the matter, so it's not perfect, but it's better than nothing. One thing that they talk about is also point of capture. So obviously there's kind of a couple factors that come into play with how well the smoke evacuators and the Bovies kind of connect with all that. The biggest one is you want to obviously capture as much of it with a time of capture, as well as you want to be as close to the point of cautery as possible. So the farther away you are from the point of cautery, the more surgical smoke evacuates into that room and gets inhaled by you guys. So on open procedures, laparoscopic, all those ones where a lot of people like to vent into the room, like I said, that disperses through the room very well, and basically it has takes the body cavity pneumoperitoneum and uses that as like a way to kind of push it out into the air. So venting into the room is not a good thing to do anymore because the particulate matter can transfer as fast as like 40 miles per hour across the room. So it can kind of shoot to the back parts of the room very well, especially like I said, if it's a pressurized gas inside the abdomen. I won't bore you guys too much, just want to make sure I hit on the big ones. Not only that, but like I said, a lot of people look at surgical smoke evacuation as like an infection control thing because they found that you can decrease the risk of surgical site infection. Obviously, because if you're cutting on one area and you have a trocar or anything else placed in there, it can kind of transfer to those trocar areas and to that smoke plume that's kind of hovering in the room. So a lot of people see it not only as like a safety factor for nurses, but also for the patient for surgical site infection, decreasing the risk of that. All right. That's pretty much it on the questions that you guys will see on there. Yep. Any questions on surgical smoke or ESU stuff?
They got any questions?
We do. Yeah.
Good employee, yeah.
And I need an attorney.
That's why a lot of states are putting into play because of not because they care about you guys, but because of the liability associated with it.
I actually worked at St. Thomas West.
So we're gonna start pulling the smoke ones on every patient.
So there is on the national level, there's a huge liability thing that there's a lot of nurses who have kind of proposed lawsuits and all this stuff. Not saying you're gonna win, you probably won't, but it is.
Surgical Techs Unite, surgical techs.
Yes.
There you go. That is one of the things, a lot of states that have been able to pass it. It's kind of fun to watch. You can go on YouTube and you can see the nurses and the techs. They've kind of coached up the Congress people and they kind of talk to it, and then all the other Congress people like get wide-eyed and like, what is all this? Because they have no idea what you guys do back here, and they have no idea what it's like. So they're like, what is all this stuff? So it's huge in a lot of states for the hospitals to advocate to the Congress people and explain what they actually do in the OR, and that's kind of one of the things that is it's nice to see when you get a good congressperson who's willing to advocate for you. ESU questions. I know that was the main point of being here. The surgical smoke thing is just allowing you guys to get those 2 CE credits for all nurses and techs. Do you guys have questions back here about these connections? Like I said, these are pretty standard. And then I can also run through this with you guys too if you guys wanted to see. Any questions on the front of this? No?
Anybody have any questions?
Thank you for scaring me.
Well, thank you for coming. We appreciate it.
Very knowledgeable. Thank you.
Yeah.